Thank you for tuning in to the TheOSCEtation web lectures. Today we will be discussing inflammatory bowel disease. Hopefully by the end of the session you will be able to appreciate the complex etiology of IBD, to understand the key differences between ulcerative colitis and Crohn's disease, and to explore differences in clinical manifestations, microscopic and macroscopic features, and management between ulcerative colitis and Crohn's disease. So, inflammatory bowel disease refers to a group of chronic intestinal inflammatory disorders comprising of two main disorders, the first being Crohn's disease and the second being ulcerative colitis. Ulcerative colitis was first described in the mid-1800s compared to Crohn's, which was reported later in 1932 as regional ileitis. Although they share clinical manifestations, they are distinct pathophysiological entities. The incidence of UC and Crohn's disease is increasing, with greatest prevalence seen in populations of Northern Europe and North America, and lowest prevalence seen in continental Asia, where UC is the most common form of IBD. It's associated with a westernized lifestyle, including diets high in saturated fats, stress, and medication use. There's a bimodal distribution in peak age of onset, and studies show that IBD is high in the Jewish population. Smoking is interestingly associated with milder disease and fewer hospitalizations in UC. We will be discussing this epidemiology in more detail now. The incidence of Crohn's disease is 9.56 per 100,000, and there is a bimodal peak age onset, one between 15 to 13 years of age, which is more common, and the next between 60 to 80 years of age. Certain risk factors have been associated with IBD, including increases in TNF-alpha, high-fat diets, and certain genetic mutations. UC is more common than Crohn's, with an incidence of about 10 per 100,000. Again, it has a bimodal peak age of onset, from 15 to 25 years, and slightly younger, from 55 to 65 years of age. UC has a very complex etiology, with some studies showing that an autoimmune process to colonic bacteria triggers off an inflammatory response. Other studies show there's a genetic component to it, with siblings of individuals who have IBD having a 17 to 35 times greater risk of developing the disease. The risk of UC is decreased in smokers, as previously mentioned. Let's discuss this complex etiology in more detail now. Recent evidence suggests that inflammatory bowel disease results from an inappropriate inflammatory response to intestinal microbes in a genetically susceptible host. Changes in diet, antibiotic use, and intestinal colonization have arguably contributed to the increased prevalence of inflammatory bowel disease during the past century. Studies show that first-degree relatives have a 10 to 15-fold increased risk of developing IBD themselves, showing the genetic component to this disease. With the rise of genome-wide association studies, many genetic regions have been found to have associations with these diseases. These include NOD2, autophagy genes 16L1, and many others have been associated with Crohn's but not with ulcerative colitis. HLA class II molecules are expressed on specialized antigen-presenting cells, and studies show that IBD has associated with certain HLA class II alleles. Other postulations as to the etiology of IBD include a defective mucosal immunity and defective mucosal metabolism to butyrates. Another postulation is that a weakened mucosal barrier causes the disease to occur. Let's talk about the clinical manifestations of both UC and Crohn's. Although they share manifestations, they are distinct pathophysiological entities. There's a very vast range of disease phenotypes and severities that can present, and these have direct implications on treatment and management of these diseases. This is a table showing the characteristic features of both, and I want to point out the key differences now. Crohn's disease, in summary, refers to the chronic transmural intestinal disease affecting any part of the GI tract. Ulcerative colitis affects the colon and is characterized by inflammation of only the mucosal layer. Let's discuss the key characteristic and differentiating features of both diseases. So, UC affects only the mucosal layer, whereas Crohn's has a characteristic transmural appearance, affecting all layers of the GI tract. Location is a key differentiating feature, with UC presenting almost always in the rectum and the descending colon. Crohn's disease can affect any part of the GI tract, yet it most commonly presents in the terminal ileum. In terms of rectal involvement, it's very typical in UC, whereas in Crohn's, the rectum is often spared. Ileal disease is rare in UC unless the patient experiences backwash inflammation into the ileum, known as backwash ileitis. Ileal disease is common in CD, however. With regards to perianal disease, this is rare in UC, but anal lesions are very common in Crohn's. The most important point to remember is that the inflammation in ulcerative colitis is continuous and usually confined to the rectum, but in Crohn's disease the inflammation is patchy and not continuous and can present anywhere from the mouth to the anus. Adults and children with IBD may present with similar clinical features. However, children can develop unique complications, including growth failure and delayed puberty. The most common presenting symptoms of ulcerative colitis include weight loss, rectal bleeding, diarrhea, and abdominal pain, whereas symptoms more characteristic of Crohn's disease include insidious onset of abdominal pain and weight loss. Further clinical features include complications of these diseases, including toxic megacolon, perforation, and hemorrhage. Crohn's disease can present with intra-abdominal fistulae, which can be either enteroenteric or enterocutaneous. Malnutrition is more common in Crohn's. However, an important clinical point to remember is that UC has a higher risk of colorectal cancer than Crohn's disease. Here is a full list of macro and microscopic features that present in both diseases. I want to highlight the key points to remember. In ulcerative colitis, crypt abscesses and pseudopolyps are very characteristic of the disease, whereas in Crohn's, skip lesions, fissures, and fistulas are most characteristic. The presence of non-caseating giant cells are very characteristic in Crohn's, being present in up to 60% of cases. The gut mucosa is often said to look cobblestone on appearance in endoscopy. Extra-intestinal manifestations of IBD are prevalent in both UC and Crohn's disease. The most common manifestations involve the musculoskeletal and dermatologic systems. Here is a table of the wide variety of extra-intestinal manifestations that can occur in both UC and Crohn's disease, that involve the hepatocreatobiliary system, for example, PSC or primary sclerosing cholangitis, as well as the ocular, renal, and pulmonary systems. Most extra-intestinal manifestations parallel the disease activity and severity and will respond to treatment of the underlying bowel disease. However, some diseases, such as PSC, need lifelong monitoring of the extra-intestinal systems, and it's really important that clinicians must promptly evaluate the complications, as these can cause emergencies such as uveitis and cholangitis. Here is a quick summary of the extra-intestinal manifestations affecting the musculoskeletal system, skin, eyes, and liver. Here's a picture of erythema nodosum and a few other pictures demonstrating what other extra-intestinal manifestations look like. So what investigations can be done when a clinician is suspicious of IBD? Well, suspicion of IBD typically arises from a combination of symptoms and screening laboratory data. Serum levels of CRP are useful for assessing a patient's risk of relapse. High CRP levels are indicative of active disease or a bacterial complication. CRP levels can also guide therapy and follow-up. Stool cultures can help us rule out infective causes of diarrhea and other patient symptoms. Recent data associate seropositivity with aggressive clinical phenotypes and rapid disease progression, so it's important to test this early, including Pianka, which is more common in UC than in Crohn's. These two tests are sometimes useful in differentiating the two conditions, but are not particularly specific, and so need to be combined with clinical assessment. The diagnosis is established by radiographic studies and endoscopy, including biopsies from the terminal ileum. These studies help us localize the disease and to differentiate between UC and Crohn's. Ileocolonoscopy defines the presence and severity of morphological recurrence and can predict the clinical course, so it's recommended in all patients where recurrence is suspected. In a patient with evidence of Crohn's disease, further investigations are recommended to examine the location and extent of the disease in the small bowel, including small bowel follow-through or small bowel enema, and less often abdominal ultrasound, CT, and MRI. Gastroduodenoscopy and biopsy are only recommended in patients with upper GI symptoms. So, the overall diagnosis is confirmed by clinical evaluation and a combination of endoscopic, histological, radiological, and biochemical investigations. Here is a photo of a UC patient with a double contrast barium enema. It clearly shows pseudopolyposis of the descending colon. Here is a picture of an endoscopy of a Crohn's disease patient. You can see the cobblestone appearance of the mucosa. Now, therapy for IBD is a rapidly evolving field, with many new biological agents under investigation. The treatment depends on location and severity of the disease, with the main aim of the treatment to induce and maintain remission. Let's have a look at the overall branches of medication needed. Starting with aminosalicylates. This includes mesalazine or 5-aminosalicylic acid, 5-ASA. These act on epithelial cells by a variety of mechanisms to moderate the release of lipid mediators, cytokines, and reactive oxygen species. The main role for 5-ASA is maintaining remission in UC. However, it's got a very large side effect profile, which means that it's a very large challenge for clinicians for tolerability of this drug. Side effects include headache, nausea, epigastric pain, and diarrhea, which are the most common and very dose-related. The second main class of drugs used is corticosteroids, which are potent anti-inflammatory agents for moderate to severe relapses of both UC and Crohn's. They have no role in maintenance therapy for either disease, and they act through a variety of inhibiting several inflammatory pathways. Here again, efficacy should be balanced against side effects, which include acne, moon face, edema, sleep and mood disturbance, dyspepsia or glucose intolerance. You also get effects from prolonged use, which could be anywhere greater than 12 weeks, which include osteoporosis, myopathy, and susceptibility to infections. There are also challenges when you try and withdraw the drug, and clinicians need to adopt a slow strategy to prevent acute adrenal insufficiency and other side effects. Another class of drug which is used in IBD is thiopurines, notably azathioprine and mercaptopurine. The main role of these drugs is steroid sparing and should be considered in certain situations for patients who require 2 or more corticosteroid courses within a calendar year. The most common cause of intolerance, which affects up to 20% of patients, are flu-like symptoms, which include myalgia, headache, and diarrhea. And these characteristically occur after 2 to 3 weeks and stop when the drug is withdrawn. One complication clinicians should be aware of is profound leukopenia, which can develop suddenly and unpredictably in between blood tests, although it is rare. Furthermore, methotrexate is effective for inducing remission and preventing relapse in Crohn's disease. However, you can get early toxicity, including side effects from nausea, vomiting, and diarrhea. Cyclosporin is another drug we can use. It's an inhibitor of calcineurin, preventing the clonal expansion of T cells. It has a rapid onset of action and is effective in the management of severe UC. Infliximab is a chimeric anti-TNF monoclonal antibody with potent anti-inflammatory effects. Numerous controlled trials have demonstrated efficacy of this drug in both active and visualizing Crohn's disease too. Therapeutic decisions depend on disease activity and extent, and these are best evaluated using a clinical activity index. Either the Truelove and WITS or the simple clinical colitis indices are recommended. When considering management for Crohn's disease and UC, it's important to consider patient preference, as there are a lot of side effects. Secondly, it's important to consider the cost of the drugs. And clinicians often have to adopt a swap and cycle policy. For example, if there's no primary response to a drug, the clinician can choose to swap out of that drug class. However, if there's a secondary loss of response, then we can adopt a cycle or switch policy within the same drug class, or increase the drug dose. Here is a summary of management that's medical only, which includes the need for supplementary diets with oral iron if signs of malnutrition are seen. It's important to know the complications of both diseases. For UC, this can be fulminating colitis and toxic dilatation, perforation and severe hemorrhage, and for Crohn's disease you can also develop strictures and adhesions. This is a picture of toxic megacolon, which was first recognized in 1950 by Marshall et al. It's defined as the segmental or total colonic distension of greater than 6 centimeters with the presence of acute colitis and signs of toxicity. Now, surgery can be a very effective and primary therapy in IBD, especially in ulcerative colitis patients, where it can act as curative therapy. In Crohn's disease, surgery is not curative, and management is directed to minimize the impact of the disease. However, at least 50% of patients will require surgical treatment in the first 10 years of the disease, and approximately 70 to 80% will require surgery within their lifetime. Urgent indications for surgery for both diseases include toxic megacolon, perforation in UC, as well as hemorrhage and obstruction in Crohn's disease. Elective surgery is limited to when medical therapy is failing or giving poor control over a patient's disease. Now, there are a vast range of surgical operations available, and I thought I'd just list a few here, including segmental colectomy, total proctocolectomy with endoileostomy, and total proctocolectomy with ileal pouch anal anastomosis. There are many classifications that exist for IBD, with the Vienna classification being most popular in Crohn's. The table shows a classification adapted by Kornbluth and Sachar in 2004, and categorises the disease according to number of bloody stools, evidence of toxicity, and complications for UC. Let's look at some case studies. Case study 1. We are presented in clinic with a 22-year-old female who is complaining of a 6-week history of 5 times a day of loose, non-bloody stools. She's got right lower quadrant pain, especially after eating, and also says that she's had 8 kilograms of weight loss over the past month. She also has bilateral knee and ankle pains. Now at this point, more information is required, and so a full history was taken. There was no significant past medical history to note, and no history of foreign travel. She's got no medications or allergies, but is a current smoker with a 5-pack year history. On examination, she had a definite and moderately tender 5 cm mass in the right lower quadrant, but no joint effusions or skin lesions were noted. So what do you think is the differential diagnosis? Well, firstly, this could be a gastroenteritis type picture, with IBD phenotypes also a differential. Beckett's disease is a complex, multi-system disorder of unknown etiology, characteristically presenting of recurrent oral ulcers. It's presumed to be autoimmune and includes involvement of lots of different organ systems. Other differentials include bowel cancer, TB, amyloidosis, and acute appendicitis. In this case, the patient turned out to have Crohn's disease after investigations were done, and it's important to re-mention the characteristic radiographic findings of skip lesions, strictures, and thickening of the haustor folds, and this helped us differentiate between this and UC. Let's have a look at another case. We are presented with a 32-year-old male who's complaining of 4 weeks of bloody diarrhea. He also has bilateral lower abdominal cramping and has signs of malaise and weight loss in the symptoms. There's no associated fever, visual changes, arthralgias, or skin lesions. He's previously fit and well and is a non-smoker but drinks 14 to 18 units a week. And he's got a family history of diabetes mellitus type 1. What do you think is the differential diagnosis in this case? So this fits with a more UC type picture. And so this patient went on to have a subsequent elective colectomy. In individuals over 65, it's useful to point out that several algorithms exist to help clinicians decide which surgery to perform. And I've given one on the screen. Clinically, the take-home messages from today's session are that IBD can be a very relapsing and remitting disease, which makes it very challenging to manage the patient. It's important to perform the appropriate investigations and check guidelines for the best treatment options. If a patient is on long-term steroids, it's important to protect their bones, which can often be affected by this. Furthermore, the increased risk of active TB associated with infliximab makes it necessary to screen for active and latent TB before this or other anti-TNF treatment is begun in patients with Crohn's disease. It's also extremely important to remember the increased risk of colonic cancer in UC patients and take this into account when managing a patient with IBD. That concludes this talk on IBD, and I hope you found it useful and will tune into the TheOSCEtation soon for more tutorials. Thanks for listening.